Good evening, and thank you so much for being here with us for part two of this special clinical seminar series on the newly identified phenotype of bipolar known as FOH. This is the second part in this series. We had a seminar 3 weeks ago on the history of the development of the diagnosis. Tonight, we are going to be focusing on the history of the identification of treatments for FOH and its preliminary treatment paradigm. For those of you who are new to CMHRC and our events, I'd like to introduce myself. My name is Elizabeth Errico, and I am CMHRC's Executive Director. CMHRC's mission is to provide guidance and resources for the early identification and management of mood disorders, bipolar disorder, and FOH in children and adolescents. And tonight with me is Dr. Demitri Papolos. He is a psychiatrist and the research director at the Juvenile Bipolar Research Foundation. JBRF is dedicated to research to determine the etiology of juvenile onset bipolar disorder and to advance the state of knowledge about its condition so that more effective treatments can be found. JBRF and CMHRC are both nonprofit organizations, and our work takes place thanks to the generosity of people like you. So if you value the information that we are providing tonight, if you appreciate the number of free resources that we make available, please consider a gift. You can make contributions through our various websites. You can go to cmhrc.org to make a gift to CMHRC or to jbrf.org to make a donation to JBRF. Now, I would like to invite Dr. Papolos to join me on screen and to let the audience know that this evening, while we are giving this presentation, you will be able to ask questions by putting them into the Q&A. Please do not raise your hand. We will not be stopping in mid-presentation to answer questions. Our colleague James is going to be handling the questions that come through the Q&A, and we'll be saving them and curating them for the end of the presentation. And we also want to remind everyone that the third event in this series is entirely a Q&A. So the entire session will just be questions and answers for the audience to ask us. The program for tonight is going to cover a quick review of the TSDD, otherwise known as FOH symptoms. And then, as I said, a history of the search for treatment, a treatment breakthrough, looking at how it occurred, understanding the treatment paradigm that has been uncovered by Dr. Papolos and his team, including medications and somatic treatment strategies. So we are going to start out, as I said, with a review of the primary symptoms of FOH as they have been written following a DSM-style format. Dr. Papolos, why don't you talk us through these?
Sure. Well, FOH, or fear of harm, as we call it, is typically been characterized by episodic and abrupt transitions in mood, accompanied by very rapid alterations in levels of arousal, emotional excitability, sensory sensitivity, and motor activity. And so that would be in the A criteria. One of the
Dr. Papolos, can I ask you a quick question about the mood cycling? Isn't it the case that in regards to FOH, we're really talking about very rapid mood cycling that can happen over the course of hours rather than over days or weeks? Is that correct?
Yeah, I think that's a good summary. Basically, it's considered within the day or ultradian cycling, so that you typically see in children with bipolar disorder that kind of mood swings. It's not anything like what has been defined as adult bipolar disorder in the DSM, but research studies have shown over and over again that it's this ultradian form of cycling, and that actually poses a bit of a problem, a number of problems. One, because those that are following strict adult DSM criteria to diagnose the condition in childhood never diagnose bipolar disorder in children, and that's a big problem for the field. So yes, it's very important to realize that it's a very rapid cycling, sometimes within the day. It doesn't have to be that, but that's typically what we see with this particular subtype.
And then it meets the DSM criteria.
Yeah, for any form of bipolar disorder. So DSM-5 includes a whole set of different conditions that are, it's sort of a potpourri of ways in which mood disorders can present, and major depression with short duration mania, major depression with insufficient criteria mania, hypomania without major depression, cyclothymia, manic or hypomanic, and mixed states. These are all DSM-5 symptom criteria, but none of them have the adult duration criteria, which is, a much longer period of time for mania or hypomania to be given the diagnosis of bipolar disorder.
So, Dr. Papolos, it seems not to be uncommon for parents to describe their children as being Velcroed to their hips. Can you talk about that as you take us through the criteria B, fear of harm?
Yeah, sure. And these are the really the defining behavioral features of the condition, and would form the symptoms of what we consider a heritable trait, which has been shown to be a heritable trait. And these all involve essentially fear. Fear that physical harm will come to self and others. These children typically misperceive and experience neutral stimuli such as tone of voice or facial expression as threatening, and respond typically as if it's a threat, whatever the behavior is, and often it's not. They develop obsessive bedtime rituals, which has much to do with their fear of the recurrent nightmares that and night terrors that occur in these children typically early on in their lives, and that is also creates fear of the dark and fear of intruders. And also we believe it's responsible for this phenomena of extreme separation anxiety and really difficulty separating from the mother, and or whoever the primary caretaker happens to be. They also, over time, develop contamination fears. Now, this is not true for all of them, but this is one of the manifestations as time goes on, and part of the developmental picture that you see with a condition. They're also very hypervigilant, which they're always looking for the next shoe to drop to see where the next intruder is coming from. And this really limits their ability to function normally, or really to develop interpersonal relationships in a normal way.
A lot of these things on this list are things that are common fears in childhood, but we're really talking about them sort of being taken to an extreme degree that prevents normal functioning.
Yes, it is really, really extreme. I mean, it's hard to imagine, but these children really are existing in a state of fear most of the time, and are easily aroused, easily startled, all of the things that you would imagine might happen if somebody were kind of in this fear state occur, and they affect their arousal levels. So so to meet the criteria for the diagnosis of FOH, this subtype, there's also this other part, which is the C criteria, which is a thermoregulatory disturbance, which is something that is really required for to make the diagnosis, because it is the really primary biological or biomarker that signals this condition. And these children typically feel excessively warm or hot at bedtime. They overheat during the night and often during the day, depending on stress or the amount of exercise they have. They feel cold in the morning, having felt hot at bedtime, and they feel excessively warm during the day, even in neutral temperatures, and have a really and this again is all on a spectrum. They can have very moderate to extreme cold tolerance, where they're typically the kids who their mothers are running after them in the winter trying to get a coat on them, and they're walking around in perfectly fine in short sleeves. With exertion, they typically overheat or sweat and sweat profusely. So these are the clinical manifestations that are both thermosensory. They have this sensory disturbance in temperature, being able to detect different temperature gradients, and they have a thermoregulatory disturbance, which we believe has to do with difficulty dissipating heat from the core to the periphery of the body and getting it out, basically, as insensible heat loss. This is something that has really, I would say, is a real cardinal feature of the condition.
And now the next diagnostic criteria is sleep-wake disturbances.
Yes, and these sleep-wake disturbances are very much tied to the thermoregulatory disturbance. And I'll go through them, the specific ones that they typically have frequent nightmares or night terrors. And these nightmares almost universally have images of gore and mutilation. And the themes are often about separation and abandonment, and also pursuit by some predator of some kind or other, an alien or a saber-toothed tiger, whatever. And this, as I said before, this is where this fear of going to sleep, because of having these recurrent, really disturbing nightmares. They also have what are called hypnagogic hallucinations, and that those are quite relatively common in early childhood, where as they're going off to sleep, they have essentially what would be called a REM intrusion. So dream sleep intrudes into the waking life, and that's when they often will see shadows or monsters on the wall. And this is what leads to this development of extreme fear sensitization that also is the characteristic of a major characteristic of the condition. They also often have excessive restless sleep. They're kicking off their covers, they're moving around in the bed, and they also have other arousal disorders of sleep that are rather commonplace but not typical, in the sense that they don't continue to recur as they do in these children.
Now, Dr. Papolos, some parents don't necessarily know that their children are experiencing sleep disruptions. In some cases, the parents themselves are asleep when they happen, so they don't witness them, or the child doesn't share information about nightmares with their parents freely, or the parents are viewing their children and thinking that they're asleep because their eyes are closed. But they may not be getting the right kind of sleep. Can you speak to this a little bit? This right kind of sleep?
Yes, sure, and also we'll I'll talk a little bit about a wonderful device that now allows us to monitor sleep rather easily and with with accuracy, look at the various sleep stages and the arousals during sleep, and which really does help to objectify the before and after problems, once treatment is initiated. And that's, I'll say it, it's called the Withings Sleep Mat, Withings. It's worth looking into. I think you wanted me to specifically answer what, Elizabeth? I'm sorry.
Well, I was just saying that sometimes parents don't know to look for sleep disturbances as perhaps as a characteristic of a mental health challenge, and they may not know that their children are experiencing some of these sleep disturbances. And so, as you pointed out, having a tool that can offer them objective data on how their child is sleeping is extremely useful. But perhaps we can talk more about that when we get to the somatic interventions that are coming up later.
Right, but let me answer the first question you asked,
Sure.
and that is that the sleep onset is often delayed, and that's a function of the temperature dysregulation. REM onset, which should occur about 1 or 2 hours into sleep, is also not something that typically happens. Either there's a shortened REM period or a lengthened REM period, and this has much to do with the fact that because of these disruptions in sleep, I would say one of the major problems is that and I'm not going to go into all the biology of it, but if you have a hot brain when you're going into sleep, one, you're not going to be able to get to sleep easily, and you're also going to have very, very wonky transitions between REM and non-REM sleep, and that's pretty much, those are the phases of sleep, and then that determines, one, how much REM sleep you get, and also how much deep sleep you get, and those are the two really major components of being able to have an adequate, refreshing sleep. And for these children, this is interrupted from the get-go, and it persists until they're treated, actually. And I just say that the particularly REM sleep, and I'll mention this because it pertains to what we believe is going on with this fear sensitization, is during REM, one of the many things that happens, important things that happen during REM, is that both emotional memory is consolidated, and also the brain sorts through old fear memories and categorizes or orders them in terms of priority, like, should I be afraid of that saber-toothed tiger tomorrow? Did I see him yesterday, or was he been gone for the last month? And so that ordering and sorting through and ridding oneself of fear memory that is no longer useful probably isn't happening for these children in the way that it would for somebody who is, having a regular sleep cycle.
Gotcha. Thank you for that explanation. Now, the next diagnostic criteria is aggression.
Yeah, and we thought quite a bit about how to describe this type of aggression. It really is a much more of what would be called in the I guess, the sociological literature as territorial aggression. It's not instrumental in the sense that they premeditate coming after somebody and harming them. It's really a reactive aggression, typically in response to any kind of limit setting and perceived threat or loss. And then there is the opposite, and that is this self-directed aggression, and seen often as headbanging or cutting or skin picking, or and manifesting cognitively as suicidal thoughts. So these are cardinal features of the fear of harm phenotype, it's important to understand the nature of the aggression that you're seeing with these children.
And then these last two diagnostic criteria, F and G.
Mm-hmm. Yeah, well, as with most other major psychiatric disorders, they're not due to a general medical condition, like hypothyroidism or hyperthyroidism. But, importantly, symptoms of FOH can overlap with symptomatology from a multitude of other DSM conditions, which really complicates the diagnosis since it's not currently in the DSM.
Right.
And we found in the family studies that we've done that alcoholism, as well as other bipolar spectrum disorders, are often seen bilineally, that is to say, in both sides of the family, and this for us supports the diagnosis.
I think it's clear from listening to you talk about this criteria how devastating these symptoms of FOH are for the children who experience them. Can you talk us through how you and your team were able to identify an effective treatment for FOH?
Yeah, well, one thing which was crystal clear was that these children typically didn't respond well to the treatments that were being administered. They were typically refractory. In fact, many of the medications that they were given, usually because most are given at least once, the diagnosis of attention deficit disorder, and they're put on stimulants, but in part, because FOH is not in the DSM, and so they get because there are a lot of overlapping symptoms. They get diagnosed with all these other conditions, and then they're given the treatments that are considered to be effective for those conditions. That's a big problem, and but at this point, hold on a second. At this point in our studies, we had a much better understanding of the specific symptoms and the course of illness. And more importantly, we understood that there were three cardinal aspects of the condition. Fear sensitization, which I've spoken about, a dysfunction in thermoregulation and thermosensation, and profound sleep disturbances. And these were really the cardinal features of the condition. So we began to really wonder what other treatments might be available that would directly affect those aspects. So in our minds, the temperature dysregulation was clear, and that we saw as a problem with heat dissipation. was clearly responsible for the multitude of symptoms that are part of sleep dysregulation and the primary behavioral trait, FOH. So, that we had determined looking at twin studies, at concordance studies, that this was heritable. And so we had this to go with when we began to search the literature for potential other, available medications that had already been approved by the FDA that could be used in the service of these children. And what we found was that a number of studies that, these were animal research studies, had shown that that there were a number of medications, some medications that affected thermoregulation, and there was one that dramatically reduced fear sensitization in animals who'd been kindled, basically, to experience that. And also had a dramatic effect on core body temperature, dose dependently lowering core body temperature, and that pointed us directly to ketamine. There was nothing else we found that could affect both of those, and at that point we really had a pretty good understanding of the circadian literature, which explained why temperature dysregulation was causing all these sleep disturbances. So while ketamine has been in the news a lot recently for depression, nearly 20 years ago we had no reason to prescribe it, and certainly no indication to prescribe an anesthetic for a psychiatric condition to young children.
Now, Dr. Papolos, I've heard you speak in the past about the moment when you were able to first see the concrete and very specific outcome of using ketamine to treat FOH in a child. Can you share that with our audience?
Sure. It really was, I would say, a breakthrough moment. Something I will never forget, because at the time I was treating a 4.5-year-old girl who was just in the most uncontrollable state, and with all of the symptoms of fear of harm. At that point, we were just starting to understand what the symptoms were, and we had just come upon this idea that maybe ketamine would work. But nothing was working with her. I mean, she was symptomatic to beat the band. And so the mother told me that she was scheduled for dental surgery, and dentists use IV ketamine all the time in kids for tooth extraction. And so I suggested that she speak to the dentist and find out whether he was willing to give her daughter ketamine. And she prevailed on the dentist to do that, very fortuitously, because the response that this child had was like better than anybody could have expected. It was really dramatic. Within, I don't know, an hour or two after the ketamine, the major symptoms subsided, and that persisted for 14 days, about around that time, which is when she started experiencing, and the parents saw the signs of overheating and the facial flushing and overheating during the day, and that immediately when that happened, the sleep disruption occurred, and following that, the whole series of fear of harm symptoms returned over a period of time. And I think the next few slides show the differences in a number of the symptoms before and after ketamine. So before she was hitting, head banging, throwing objects, screaming. And after ketamine, there was no aggressive behavior to speak of until things, returned, the thermoregulatory problems returned. And then she was, the symptoms were considerably less severe and frequent during this period when she was stable.
And so this slide shows the sleep improvements.
Mm-hmm. Yeah, there was really dramatic improvement in sleep. I mean, this young lady was, she was not able to self-soothe. She would come into her mother's room multiple times a night. She was terribly afraid of the horrible nightmares she would have. But she was really unable to tolerate much maternal affection. She couldn't cuddle or hold her mother's hands, and was frequently rude. She was, it was just really, really severe in a 4.5-year-old. I mean, it was, this was a terrible twos multiplied 100 times. And as you can see in the slide, there was really significant changes. I mean, she was affectionate with the mother after the ketamine. She was more like a neurotypical child.
So then we see this core feature of fear of harm.
Yeah, and as I mentioned, so with the thermoregulatory disturbance goes this the fear of harm symptoms. She, previously she'd been clinging to rituals to feel safe. She needed transitional objects sent to feel safe. She was hoarding food and hoarding, toys, and was terrified of being alone in rooms in the house. And all of these things were either significantly reduced in frequency or they were absent during the period of the effect of ketamine.
And that was also the case with psychotic features and delusional symptoms.
Yes, exactly.
So at the end of this 10 to 14 day period after the IV ketamine administration at the dentist, all of the symptoms started to slowly reemerge, correct?
Yes, exactly. And, we couldn't, at that point, it would have been very hard to tell the mother, I'm sorry, we can't give ketamine to your daughter. So I took a leap of faith and found a way of administering ketamine. Not a drug I had any experience with, but found out that it could be compounded as a intranasal spray, and you could titrate it, very slowly. And so that's what I did. And and went forward, and that was sort of the beginning of developing a protocol for treating this aspect of the condition.
Dr. Papolos, can you speak for a minute about that? I heard you say that you couldn't tell this mother that you had discovered something that was going to help her child. You couldn't tell her that you'd found that and that you weren't going to give it to her. It seems like there's a real ethical piece of this, that when you find something that works, to be able to provide it.
Yes, I mean, we'll particularly if it's doesn't have an indication to be used for a particular condition that's been approved for by the FDA. Now, ketamine's had been approved at that time for over 30 years for use as a anesthetic, and it's still the most widely used anesthetic around the world, not in the United States, but around the world because it's safe. It's I think maybe the only anesthetic that doesn't cause respiratory depression, which would require, as most anesthetics do, the availability of an anesthesiologist who can monitor respiration and be able to provide respiratory support through ventilation, if need be. But this didn't have that effect. So basically, being able to give it was going outside of the boundaries of what of normal clinical practice to do that. And physicians are allowed to prescribe medications, and often do, that are not that are off-label, meaning they haven't been approved for a particular drug. That happens all the time. But this drug particularly carried a lot of heavy baggage because it has been used as a recreational drug of abuse, and so it's a controlled substance, so it becomes more difficult to do that. But in any case, although as physicians, we all take an oath not to do harm, but in this case, it seemed to me that the ethics of not treating was really overriding, because it would do harm if she weren't continued on ketamine.
So this led to further testing of ketamine.
Yes, we started. We began doing this systematically. This was the first case, as I said, and it allowed me to develop a way that was effective, that it could be administered safely, and which I think we'll talk about in a little while, what the actual protocol was that evolved out of this.
Can you give us an update on where this 4.5-year-old from years ago is now?
Well, yeah, I can happily say she's been treated all these years. She's been on lithium for the mood stabilization, and she has been on ketamine, which we were able to reduce considerably to once, I think, a week, and a very, very low dose. She just graduated from college this past May. So happily, she's done very well, and she was stable throughout her whole childhood and adolescence.
That's wonderful. So can you now describe your current understanding of how ketamine may be exerting its effects on the central nervous system to address these FOH symptoms?
Yeah, I think the mechanism for how ketamine works, even for depression, is not really fully understood. But there's been a lot of work in looking at its effects in animal research, and so we have some clues as to how it may be working. I think for FOH, which is not the same as treatment-resistant depression, which is what it has a clinical, it has been approved by the FDA to treat in a different form. But typically, one of the things that's important to point out, that it's while it's been a lot in the news lately for depression, as I said, we didn't really know how it would work in FOH. But given the symptoms that we're actually treating, it may very well be that because of this rapid effect that it has on a very specific gene, which plays an important role in thermoregulation, sleep, depression, stress resilience, and fear formation and aggression. That this is a gene that gets induced significantly by ketamine, and so one of the things that was always puzzling about ketamine is it's very rapidly metabolized and excreted from the body, like within 24 to 30 hours. It's just not really available. It's not doing anything physiologically. It's not affecting receptors or at that point in terms of being in the blood at a certain level, but it can have an effect sometimes for up to a week or two, depending on the dosing that you're using, and that implies that has something to do with gene expression, which would give a much more longer, prolonged clinical effect, because it's operating at that level, not at the receptor level. And so this particular gene, which has where there's been a good deal of research done, and perhaps one of the earlier I think important studies, it was done by, and I think the next few slides are going to illustrate this. They were done by Dr. Ronald Duman's group at Yale, and what they found, it's a very interesting finding, that the effect of ketamine to promote fine dendrite growth in neurons. So these are the outpouchings of neurons that when they increase in size, basically there's that leads to branching and more synaptic connections in the part of the brain where you see this dendritic growth, and ketamine dramatically within an hour was shown to dramatically increase the dendritic outpouchings, which suggests that this is going to influence brain plasticity and produce new neuronal growth, which is, a sine qua non for new learning new behavior. So perhaps it's through the development of new synaptic connections that promotes new behavior that could be one of the ways in which it's having a clinical effect.
So, yeah. Taking it one step further, the animal models have something to suggest.
Yes, that that the BDNF gene plays I mean, there's separate studies that were done by another lab, I think in Israel, that looked at I guess avian species, where they were looking at the BDNF gene in terms of its importance for setting the thermoregulatory set point in the brain, in that species anyway, and they found that it had a significant role in establishing the thermoregulatory set point in early life, which implies that it can continue to do that if you increase the the expression of the gene in the hypothalamus, which is, and one of the places that's where temperature thermoregulation is essentially monitored, and BDNF is loaded in a particular area where there are warm and cold receptors in the brain that are receiving information from from the body about temperature. So again, this is another potential role for the fact that ketamine induces this gene may also be essentially, at least temporarily, changing the set point. I mean, one of the clinical findings that we have seen over and over and over again with administering ketamine is that within 5 minutes, there is what we've begun to call a heat blow-off, that there's an enormous blow-off of heat. The face can become very flushed and enormous. So there's it clearly is shifting heat from the core to the periphery, which I think is an immediate produces an immediate clinical effect. And if it has this effect in humans that I just talked about, then it may be, resetting the set point for the temperature.
Now, in 2017, you published a paper which was a longitudinal study of ketamine as a treatment for FOH. Can you share some of those findings with us today?
Mm-hmm. Yeah. Sorry. Yeah. So we've done two studies, one an acute study and one a more longitudinal study. But with the acute study, we wanted to demonstrate, obviously, whether it was effective in a group of FOH patients. And what we found was a really significant, rapid, and strong positive response in over 80% of the sample, which is very, very high for any psychiatric drug. I mean, this was not a placebo-controlled study, so it's a naturalistic study, which is, to really demonstrate efficacy, you have to do a double-blind controlled study. But this was the first study that has been done with the ketamine in this group, and it certainly surpassed our expectations. The fact also is that this drug is extremely inexpensive. I mean, the cost per month is less than $100 per patient, because it's a generic. It's been on the market for over almost 35 years now or longer. So it's not subject to pharmaceutical patent.
So there's, sorry, go ahead.
Yeah. So I was going to sort of summarize that. So fear sensitization and thermal dysregulation really are along with the sleep problems, are cardinal features of the phenotype. And it was that understanding in the literature review that revealed that the only drug in the pharmacopoeia that reduced both in these animal studies was what led to our selecting ketamine and over a decade of research in terms of treating the condition and trying to figure out what this thermoregulatory problem may be and what's the underlying biology for it.
And on the next few slides, we have some concrete data to share on the pre and post outcomes of ketamine.
Yeah, we looked at these child bipolar questionnaire dimensions, which we spoke about. This is what was developed as a tool for really screening, and we used this. One of the things we used in the study to look at pre and post treatment with ketamine, and you can see on the left column. And this was, I should say, a systematic chart review of a case series from my private practice, and included cases who were clearly refractory to mood stabilizers, some mood stabilizers, antipsychotics, and benzodiazepines. And it was a study that this was I'm talking about the first acute study, was in 12 treatment refractory youth, 10 males, 2 females. They were aged 6 to 19. And we made a comparison between the routinely collected symptom measures 1 to 2 weeks prior to and after the administration of ketamine. And these are all of the primary dimensions on the CBQ that are typically affected in this condition. And you can see by the p-values are quite significant at, very, very significant. So this was the, sort of the capper in terms of our feeling that we were on the right track. In the next slide, you can see that the differences in the total score. There are 2 primary indicators. The CBQ total score, it's just the adding up the 65 items. It's a Likert scale, so it's graded from 0 to 3, I think it is, or 1 to 4. Can't remember. And just adding those items up. And then there's the core index, which is, there's an algorithm that actually provides a diagnostic possibility of having the FOH phenotype. And you can, and then the FOH score, which is just those items that are considered part of the FOH trait. And you can see again this rather steep change in all of these dimensions, which are which are basically characterizing the symptoms that are present in this condition.
And there was another paper that you published later in 2019, correct?
Yes, and that was a longitudinal study. That we did, which was in a much larger sample, I think about 48 to 50 cases, that we looked at individuals who'd been treated for 6 months to, I think, 3 years. And this was really an attempt to look at potential side effects of giving this drug particularly to children for that long a period of time. And and again, we saw rather dramatic improvement. And except for a few cases, I think I don't remember, it was quite a while ago in the study, whether anybody was had to leave the study because of side effects. But because of the protocol that we use, which is pretty customized for each individual, those acute side effects are not typically a problem. But we did not see any longitudinal side effects that lasted beyond the acute period of 1 to 2 hours after the administration. And that was we were very pleased to see that. And this was what we used to begin to think we would be able to do a double-blinded placebo control study, and get approval from the FDA to go ahead with it, particularly in this population. But, there was little vested interest in funding research into a generic drug that costs pennies. And also, and the FDA was quite rightly skeptical when it came to using this drug in pediatric trials. We went up twice with 2 FDA reviews, and from the comments, we realized no matter how we amended the first proposal, they were going to impose such strict limitations on a number of times we could give ketamine that, and it was very costly. I mean, we'd raised the funds to do the study, but we realized that we would be doing the study, but we wouldn't be giving the drug long enough to really be able to demonstrate the kind of efficacy that we were seeing, using the protocol that we had. And that really was led us down another path. And we redirected our efforts and began doing other research to try to hone in on the the marker, the temperature, thermoregulatory marker, and try to more carefully define the phenotype so that we could be presenting it as we are today to so all of the published works that are mentioned, I think, on this slide that you're seeing, they're all available on the JBRF website as PDFs. You can download them if you're interested in, and the whole basically history of when we started and how we developed this, or I guess delineated this phenotype, which we believe is something that really exists in nature. It's not something invented by consensus. They're all there, and you can get access to them very easily.